Hello and good evening, everyone. I'm sure you're all busy watching the IPL match, very interesting match going on right now. But I would like to welcome you all to this INICET recall of general surgery questions, which the exam was held on Sunday. So I am Dr. Nishanth Lakshmikanta. Now, disclaimer from my side is that a majority of these questions have been sourced from students and various other sources. So there might be an error in the grammar of the question. Like certain times they might have asked which of the following are, and the question what I would have received is which of the following are except or not. So if there is something like that, please do put it up on the chat box, or you can even send me a mail or put it up on the comment section, and then we'll go ahead with it. And like I said, I have no conflicts of interest. So please don't hold me if some question goes here and there. I will give you my justification as to why I think this is the particular answer with references from standard textbooks. And only other thing what I request from you guys is, because I'm in front of the screen, once in a while, please keep putting up the IPL score on the chat box and do me a favor. So let's start off. First, let's cover all the GIT questions. Now, this is one of the easiest questions that I felt it was amongst all the questions in general surgery. Which is the most common hernia in females? And the answer is indirect inguinal hernia. Okay, no two ways about it. Now, I've said this n number of times, be it our prepathon or whatever the lectures are there in the app, or even our notes and even the crash course n number of times. This is a straightforward one liner. However, there was a little bit of confusion among students where they felt the answer was femoral hernia. Okay, now hello, good evening, Tejasvi sir. Good evening, expert witness. Thank you. Okay, so the why does this doubt arise that femoral hernia is the most common hernia in females? No, that is wrong. It's actually indirect hernia. But in femoral hernia, if you compare female is to male, females have a higher incidence of having femoral hernia. Now let's look at the reason why, so that we get the doubt out of our mind. Now the femoral ring is bounded by three ligaments, all right? The lacunar ligament, the Cooper ligament, and the inguinal ligament. And on one side, it is bounded by the femoral vein. Now ligaments you can't change because they are structures. But look at this, the femoral vein. In women, all veins and arteries tend to be slightly smaller in caliber as against male, correct? So if the femoral vein is slightly smaller, automatically the ring becomes slightly more because you have more space. So there is a higher chance of a hernia occurring in female. So typical example, if the incidence of inguinal hernia is 1000, male is probably 800 and female is 200. But if you look at femoral hernia, the incidence will be 10. In that, the female might have 7. Okay, like 7 females might have femoral hernia, 3 males might have femoral hernia. If you look at the broader picture, still 200 inguinal hernias versus 7 female femoral hernias. Okay, so straightforward, no confusions. The answer is an indirect inguinal hernia. Now let's move on to some other GIT topics that too in the upper GI tract. I've told this n number of times, stomach, esophagus, they are concentrating left, right and center, and even this time also we've got a lot of questions. So this question was straight up on GERD. Now first things first, in GERD, the way they present is that they can either have typical symptoms or you can have atypical symptoms. Now your typical symptoms are nothing but your heartburn, okay, heartburn, chest pain, reflux, water brush. Okay, so basically it's the acid coming up the esophagus. Normally the acid is in the stomach, and the stomach is an organ which can tolerate the acid, but esophagus is not. So if you see the acid kind of refluxing up into the esophagus, that is when they get all these symptoms. Now if the acid goes more over and beyond the esophagus, that means if it starts coming higher up and starts involving the larynx, the pharynx and the trachea, that is when you're going to get your atypical symptoms, and that is what this question is based upon. So the question was, which of the following are complications associated with GERD? Asthma is a complication, laryngitis is a complication, pulmonary fibrosis is a complication, and this is where there is a bit of dilemma. Okay, chronic cough is a complication, but in the options, few of them said that there was an addition where they said there is increased phlegm. Please note, in GRD, the chronic cough is dry cough. It is dry cough. But if the question said increased phlegm, then it is not a complication of GRD. Okay. So if increased phlegm is not there, then the answer will be 1, 2, and 3. But if they're saying increased phlegm is there, then all the four answers or all the four options must be marked. So this is straight out of Bailey and Love. Okay, all your atypical symptoms are also called as extra esophageal manifestations of GERD. So here, like I said, chronic cough is dry cough. Apart from that, the patient can have laryngitis, they can have asthma, they can have dental erosions, they can have sinusitis, they can have pulmonary fibrosis, pharyngitis, and even otitis media. Okay, they'll have recurrent episodes of otitis media. Moving on to the next question, pretty straightforward. So here, a middle-aged male patient complains of halitosis, regurgitation, weight loss, and they've given a barium swallow. So let's look at the radiology in the last. So let's just dissect this question based on the symptoms that we have. Halitosis, regurgitation, weight loss. So of this, the danger symptom is weight loss. So let's concentrate on weight loss. So if you look at the options, there are only two possibilities for weight loss. Okay, one is achalasia cardia, one is esophageal carcinoma. Diffuse esophageal spasm, they're going to have a lot of chest pain. And Zenker's diverticulum, more of halitosis, but they're not going to have weight loss and they're not going to have regurgitation. Okay, so now the option comes down to achalasia and esophageal carcinoma. Now let's understand this. In esophageal carcinoma, there is a growth there. So the patient will only have dysphagia. They'll have difficulty in swallowing. Whereas in achalasia, the lower end is gone into a stage of spasm. So the patient will keep on eating food, the lower end will keep on dilating, and eventually the patient is going to have a dilated esophagus like this. Okay, or it's also called as a sigmoid esophagus. Now because it's so dilated, whatever they eat will keep on getting collected in the esophagus, and probably 12 hours or 14 hours later, all that food, whatever they've chewed, the undigested food, everything will come out, and that is what we call as regurgitation. Vomiting is if the contents come from the stomach. Regurgitation is if the contents come from the esophagus. So regurgitation is pathognomonic for esophagus, okay, or esophageal disorders. So regurgitation is a symptom of achalasia cardia. So right now, just with the symptoms, you can make out that the answer is achalasia cardia. But if you go ahead and you look at this barium swallow, you can see there is a dilated esophagus with a bird's beak or a rat's tail appearance, and this is typical of achalasia cardia. Now this I've told n number of times, like I said, it's in our app, and even the recent INICET prepathon that we did, even there I gave you the exact same thing, that the patient will have regurgitation, bird's beak, rat tail appearance, and the investigation of choice is to do a high resolution manometry. Now moving on, now from the esophagus, let's move down into the stomach. Now in the stomach, the question was, which of the following is not a marker for GIST? Now GIST is gastrointestinal stromal tumor. Now here there are two things that you need to know. The most common marker for GIST, all of us know, is your c-KIT, that is your CD117. Good evening, Dr. Arpit. Good evening. So first one is c-KIT. This is the most common mutation and seen in 80 to 90% of patients. Next is your platelet derived growth factor alpha. Okay. Now patients who have these mutations are the ones who respond to imatinib. Okay. And those who don't respond to imatinib are a variant of GIST, and this is where you're going to have your SDH mutated variant of GIST. Now for these patients, they will be negative. They will be negative for c-KIT, and they will be negative for your platelet derived growth factor receptor alpha. Okay, so they'll be negative. That means these patients do not respond to imatinib. They do not respond to imatinib. That's all. That is the idea behind knowing these tumor markers. So even though it looks like a pretty straight one-liner where you have to mug up, this is the concept behind it. So from the question or our explanation right now, you can make out that SDH is a marker of GIST. c-KIT, that is CD117, is a marker of GIST. Platelet derived growth factor receptor alpha is a marker of GIST. The NRF1 is not a marker of GIST. So this is your correct answer. Now moving on lower down into the colon, the next question that was asked was based on inflammatory bowel disease. So the question they had asked is, which of the following is true? I think this was a multiple correct answer question. If it was a single best answer, please put it up on the chat box. But I think it was a multiple correct answer question if I'm not wrong. Now the question that they'd asked here is, in contrast to ulcerative colitis, which of the following is true for a Crohn's disease? Now before we get into the answer, Dr. Ranjana had beautifully summarized this in her lecture on patho. Now we'll just take up the same table and I will see one or two points. So let's just understand the disease so that we can get the answer right. Now in Crohn's disease, it commonly involves the ileum, that is a small intestine, and they're going to have skip lesions. That means, let us say from the duodenum. If duodenum is involved, then jejunum will be normal. Then if jejunum is normal, then ileum will be involved. So I'm just giving you an example. So like that, there'll be patchy areas which are involved, and in between you're going to have normal tissue. Same thing with respect to the colon also. They're going to have skip lesions, but they're predominantly more in the small intestine. Whereas in ulcerative colitis, as the name suggests, colitis, that means it involves the colon. Okay, it involves the colon. And here, there are no skip lesions. It is just one continuous inflammation. Now, simple question. If there is inflammation, that means there will be erythema, that means there will be mucosal ulcers, that means there will be bleeding from the colon and the rectum. So if you see blood in stools, what is this called? It is called hematochezia. Okay, this is called hematochezia. Now moving on, in Crohn's disease, you're going to have transmural involvement. That means all the layers, mucosa, submucosa, muscularis, serosa, everything is involved. So let's assume if everything is inflamed and the entire thing is very weak and it goes and attaches to another structure, that inflammation will cause erosion across the layers and these patients will have fistula. So remember, fistula is more common in Crohn's. Why? Because there is transmural inflammation. So that is why you're going to have fistula. And when it comes to risk of malignancy, ulcerative colitis have an increased risk of malignancy as compared to Crohn's disease. So now with this information in mind, let's try and solve this question. Now they said that Crohn's disease seldom presents with hematochezia, which is true. Seldom means rarely presents with hematochezia. So that means this is the correct answer. Increased frequency of perianal fistula, I've already told you, transmural involvement, so they can have perianal fistula. And here the fistulas are multiple in number. So what is that called as? It is called as a water can perineum. Okay. And skip lesions are seen in Crohn's. Yes, that also we said. And risk of malignancy is more in ulcerative colitis. It is not in Crohn's disease. So if this was a multiple correct answer question, then any option which involved these three statements will become the right answer. Or if it was a single best answer, or in case that said not, then this becomes a correct answer. Now let's move on. Now let's talk about breast and endocrine disorders. Now this question, they have said there is a 50-year-old female and they've even said that she has breast cancer. There is ulceration of skin, nipple retraction and inflammatory signs. Now this is very, very important. Had they mentioned inflammatory signs, have they mentioned inflammatory signs in the question? Okay. The feedback I got was some people said they couldn't remember. Some people said rather than inflammation, they had mentioned redness and tenderness. Okay. Now I'll tell you why this is important. If there was, good evening, Ishita. Okay. Now, if there was redness and tenderness, then the staging of breast cancer changes. Okay. Yes, redness present. Thank you, Dr. Rishikesh. So now the game changes. Now, again, I've been telling n number of times in CA breast, T4 classification is a must. You should know about it. So I've discussed about this in our video lectures. T4A is involvement of the chest wall except pectoralis major, that is rib cage, intercostal muscle, serratus anterior. T4B, ulceration, powder orange, satellite nodules. Dimpling and puckering is not part of T4B. And T4C is if both T4A and T4B are there. Now, T4D is inflammatory carcinoma. Now, if they had mentioned redness and tenderness, this becomes inflammatory carcinoma. So now the answer becomes T4D, but T4D was not in the option, it was T4B. So that was not the correct answer. And moving further, I've repeated n number of times, you need to know staging of CA breast, even though you don't need to know A, B, C, that is 2A, 2B, 3A, 3B, or at least roughly need to know what is stage 1 and 2 and what is stage 3. I've given you a beautiful mnemonic here. Write 3, 2, 1, 0 and write TNM. Okay, so T2, N1, M0 is the cutoff. Anything less than this becomes stage 1 and stage 2, for the exception of T3, N0, M0. Okay. Thank you, Dr. Dhanalakshmi, 7342 9.3 hours. Thank you. Okay. You got a smile on my face. Good. So I know that someone's watching. So like I said, T3, N0, M0 is an exception, which again falls into stage 1 and 2. Automatically, anything else apart from this directly falls into stage 3. Don't have any confusion in your mind. And if it is M1, it becomes stage 4. Now in this scenario, we know it is not stage 1, stage 2 because it is T4D. We know it is not stage 4 because there is no mention of metastasis. So automatically in such a scenario, the answer becomes stage 3B. Okay. Forget about 3A, 3B. I told you they will not go into depth. They will only ask you stage 3 and you need to know stage 1 and 2. So it is not stage 4. Why? Because there is no metastasis. It is not T4B and no metastasis cannot be an answer. Okay. So this was the correct answer for this question. Now moving on to breast. Now this is a very funny and difficult question, to be very honest. So here they have asked, what is ER positivity in context with breast carcinoma? Now let's look at the options and try to decipher it. First is diagnostic marker. Is ER a diagnostic marker? No. Okay. What I'm trying to say is, if somebody is ER positive, does it mean they have breast cancer alone? No. Okay. If, for example, a desmoid tumor is also positive for ER receptor. Sometimes even thyroid has ER positive receptors in it. That doesn't mean just because you found ER positive, it means breast cancer. So it is not a diagnostic marker. Diagnosis is histopathology. Next is prognostic marker. We'll come to that later. Next is a surrogate molecular marker. This is for your luminal A, luminal B, subtyping. Those are called as surrogate molecular markers. So ER alone can't determine that. So you need multiple other things. Now you are left with prognostic and predictive marker. Here it comes. In Robbins, they said ER is both prognostic and a predictive marker. Now let's understand why. If a patient is ER positive, prognosis is good. That is what it means. Now at the same time, if the patient is ER positive, you can predict whether you can give this patient hormonal treatment and you can predict how they are going to respond to it. So that's why it becomes a predictive marker. And in certain articles, they've even said it predicts the prognosis. Okay, so it's a prognostic, but it is a predictive marker. Now let's look at surgical textbook. This is straight out from Bailey and Love. Okay, now in Bailey and Love, there is a table where they have given the various prognostic factors. Here ER is not given. Here they have put a lot of emphasis on the Nottingham's prognostic index. In this Nottingham's prognostic index, three things. I've given you the mnemonic already in our prepathon. S and G, solitary nodular goiter. Remember it that way. S stands for size, N stands for axillary nodes, and G stands for grade of the cancer. Okay, so amongst these, nodes is the most important prognostic factor. So remember, whatever is in the center is like a king. Okay, a king with people around them. Okay, so the one in the center has the most important role. So nowhere here they have mentioned about ER. So if you go by Bailey and Love, if you ask me which is the single best answer, I would choose predictive marker. Okay, so this would be my choice, that ER is a predictive marker. But like I said, AIMS, INICET or AIMS examiners, whoever set the paper, you can expect one or two bouncers like this, and we'll see what the final answer is. So now let's move on to urology. Now here the question was, a middle-aged man with recurrent episodes of flank pain, hematuria and UTI. So with respect to flank pain and hematuria, you know it's a kidney stone. Okay, that's why it's gone and got stuck somewhere in the ureter, causing a lot of pain. So it's a typical ureteric colic. And the patient has UTI. And further they go on to say the patient has alkaline urine. Either they'd used the term alkaline or they'd mentioned pH of 8 or 8.4. So one of these two terms were mentioned there. So this is where you need to use a little bit of sense. Whether if they mentioned 8, that means it's alkaline. Now with this, forget about the image. Now there was a lot of confusion about the image, whether it was coffin lid or envelope. We'll just leave it to the side. Just with the help of these two information, that is alkaline or pH being 8, let us try and figure out the options. Calcium oxalate. Oxalate means oxalic acid. Now, can acid be an alkaline pH? No. Correct? So, this is out of question. Next, uric acid. Can acid be an alkaline pH? No. Okay. Triple phosphate is magnesium, ammonium, and phosphate. Now, can this be alkaline? Yes, because everything has a plus charge associated with it. Last is your cysteine stone. That is the option that we are left with. Cysteine, I've given you this mnemonic. Okay. Cysteine sounds like 16. Okay. Somewhat sounds like 16. 16 has 6 in it. Okay. 6, that means you're going to have a hexagonal crystal. Okay. This is your cysteine stone crystal. So with this information, we know that the answer boils down to triple phosphate. Now let's look at the image. This is a clear-cut coffin lid appearance. Okay, straightforward coffin lid appearance. So this is seen in triple phosphate stones, or it's also called as a struvite stones. Again, this is straight out of our lecture videos. I have mentioned here, struvite stones are also called as triple phosphate. The MAP, that is a magnesium ammonium phosphate. They're infection stones. Here the patient had UTI, correct? Alkaline urine, we have mentioned. Staghorn, sorry, coffin lid appearance of the crystals, we have mentioned, and the same has been given in the image. And these patients have a Staghorn calculus. Now moving on, another question on neurology. They have asked which of the following statements is not true regarding Wilms tumor. Not true. Okay. Now remember, in pediatric malignancies, two important tumors that you need to know. One is Wilms tumor and the other one is sorry. Okay, one is Wilms tumor, the other one is a nephroblastoma. So neuroblastoma, sorry. Wilms tumor and neuroblastoma. Neuroblastoma is the most common. Wilms tumor is the second most common. Wilms tumor, you need to know, does not cross the midline. Does not cross midline. Okay. So whereas neuroblastoma can cross the midline. Okay. So these are important points that you need to know, differentiating Wilms tumor and neuroblastoma. Otherwise, both of them are very, very important topics. Now, like I told you, it's a pediatric cancer. So automatically it is seen in younger age groups. So less than 5 years of age. So this is a correct statement. Now it presents as an abdominal mass. Yes, because cancers are usually painless. So if they're painless, that means they'll never notice in the initial stage. It usually grows. The baby will come with abdominal distension, and when you examine, there will be a mass. Good evening, Dr. Shimona. Okay, so they'll come with an abdominal mass. That is also true. Lung metastasis is rare is not correct. They usually, because they come at an advanced stage, these patients invariably have lung metastasis. And the treatment for Wilms tumor is surgery. Surgery is gold standard. Along with that, you need to give them good chemo and radio to have a very good survival rate. So these three are the correct statements. So then this question had asked which of it is not. Then the correct answer becomes lung metastasis is rare. They usually, by the time they come to you, they already have lung metastasis. One more question from GIT. I think we had missed that. Very, very important. This was an image-based question where they ask you to identify the instrument given here. Now, look at this instrument here. There is a tube with a flange. You can see there is a tube which going all the way here. There are various connectors that have been shown here. Various connectors. You have a syringe, whole towel, and a lot of other instruments. Now let's look at the option. Orogastric tube. I'm sure all of you know Riles tube. This is not a Riles tube. ICD. I'm sure all of you have seen. This is not an ICD because there's no ICD bag here. Okay, and this seems to be too small a tube for you to call it an ICD. Okay, now the option comes down to between central line and a peg tube. Now this is a peg tube. Okay, now this is straight out of my video lecture again. So here I had shown you the image of how a peg tube looks from the inside and the outside. From the inside you can see this flange, this is an endoscopic view, and from the outside you can see this tube with the various connectors of different size through which you can feed the patient. So this was a peg tube, the image what they had shown. Now for your benefit, we will also cover the other instruments that have, or the other options there, so that you can get these answers right in case they're asked in NEET. Now in a central line, you're going to have multiple entries or multiple lumens. We call this as a triple lumen central line. You can have a double lumen central line. Now you can see here, all the three lines merge and eventually you have a single tube. Whereas in a peg tube, it is a single tube which goes, whereas central line, you can have multiple lines which converge and then become a single line. So this is a central line. This is not a peg tube. Of course, this is a Riles tube. I'm sure all of you know you're going to have lead shots here, and you're going to have radio opaque lines all along the Riles tube, which will help you tell where the tube is, whether it is coiled, etc., so on and so forth. This is an ICD tube. You're going to have tubes with holes in them. Here also you're going to have radio opaque lines running. You're going to have tubes of various sizes, and this is important. You need to know how an ICD bag looks like. Now the important feature for you to differentiate an ICD bag from a Euro bag or a simple collection bag is the fact that at the bottom you're going to have a triangular end which is usually filled with water, and you're going to have a tube which runs all the way down to the center from the top to maintain the underwater seal. Okay, to maintain the underwater seal. So this is an ICD bag. A Eurosac bag will not have all this. It will just be a straightforward bag without this triangular shape at the bottom and the tube running through the center. Now let's move on to trauma. This was a 35-year-old patient. If there are any doubts or questions, please put them up and we'll clarify them. Now this is a 35-year-old patient who has sustained a head injury, and the patient lost consciousness for a brief period, and then once the patient woke up, he had severe headache, vomiting, and drowsy. GCS was 10. That means the patient had low GCS. And this is the important point, okay, important one, and this was mentioned in the question. That's what a lot of students told me, that the pupil was dilated on one side. That means ipsilateral pupil was dilated. Now please keep it in mind. Now before you going into the image and all, ipsilateral pupillary dilatation means there is midline shift, there is compression. Okay, the brain has pushed, and that's the reason the nerves get compressed and the patient will have pupillary dilatation, because there will be herniation of the brain stem. Okay, so that is the reason why you're going to have ipsilateral pupillary dilatation. So this is important. This means midline shift. And then they had given you an image, okay, where you had a biconvex shaped hemorrhage which was inside the skull. So this is typical of a EDH. This all of us know. This is pretty straightforward, EDH. Now EDH is going to have lucid interval, all that is apart. Here the question was, how are you going to manage them? Now first and foremost, this is a hemorrhage, correct? So you can't give anticoagulants. Instead you have to give something to stop the bleeding, not worsen the bleeding. So anticoagulants is out of the question. Sorry, anticoagulants are out of the question. You can't sit and observe because the patient is having midline shift. He has a lot of headache, vomiting, drowsy. So you just can't sit and observe them. If the GCS is 15, observe. That's a different issue. Now you have to do something. That boils down to whether you want to do surgery or whether you want to give mannitol and monitor the intracranial pressure. If there is midline shift, the answer directly becomes surgery. Okay. Now this was the dilemma. The students felt that in certain images there was no midline shift. Certain people said there is, certain people said there's not. There's no point debating on it. But like I said, before you go to the image, a lot of clues are there in the question itself. And the fact that pupil was dilated itself is an indication that there was a midline shift. So again, this is right out of our lecture. So I told you for EDH, just a quick recap. Most common site is fracture of the squamous temporal bone, where the middle meningeal artery gets traumatized, and that is the most common source of bleeding. And then these patients will have lucid interval. That means they will have initial concussion injury where they would have lost consciousness, then they wake up, they'll be normal. Then as the pooling of blood increases and the patient has a brainstem herniation, they'll again lose consciousness. So they'll have a period of normalcy in between these two episodes of loss of consciousness, and that is called as a lucid interval. And like I told you, pupil, you will have ipsilateral pupillary dilatation. and on CT you're going to have a biconvex shaped hemorrhage. Why it is biconvex I've explained. Please go and watch the lectures. Now, indications of surgery. When are you going to operate? Only two indications. One we already know, we have just discussed, if there is a midline shift. Second is if the volume of blood is more than 30 cc. That is, whatever you estimate on the CT scan, if it's more than 30 cc, that means you need to operate. What are the surgeries you're going to do? You can either do a craniotomy or you can do a burr hole. Of these, you will do a craniotomy. Why? Because you're going to take out a chunk, decompress it. Not only that, you need to stop the bleeding, correct? So you need to stop the bleeding. So you can coagulate the bleeder, put the skull back, close and come. So this is called as a decompressive craniotomy. Whereas in burr hole, you're just going to make a hole, allow the blood to come out. But what about the bleeding middle meningeal artery? You don't expect that to stop like a vein or a small ooze. Middle meningeal artery will continue to bleed. So burr hole is not an ideal surgery for EDH. Instead, burr hole is done for SDH, subdural hematoma, that also for chronic SDH. Okay, in elderly patients, long standing, probably 2 or 3 weeks later, that is when they lose consciousness following trauma. So 2 or 3 weeks will be there. That time it's an organized hematoma. You don't expect them to be continuously bleeding. That is where you can do a burr hole and get away with it. Another question on trauma, this was pretty straightforward. Which of the following is not done? Okay, it is not done in primary survey. So we know that primary survey as per ATLS protocol is A, B, C, D and E. Airway, breathing, circulation, disability and exposure. Now let's look at the options. Intubation is done in airway, correct? Yes, I'm sure all of you agree. In breathing, what are we looking for? Tension pneumothorax or hemothorax. So if there is something which is compressing and not allowing the patient to breathe, what are you going to do? Either you're going to put a needle or you're going to put an ICD, correct? So ICD insertion is under breathing. So that brings us down to two options. Is it NCCT or is it a chest X-ray? Now, if you remember in secondary survey, I told you there is a concept called as whole body CT scan. So NCCT is a non-contrast CT scan. So it's still a part of this whole body CT. So if you remember, whole body CT, that is a WBCT, is part of the secondary survey. So automatically NCCT becomes secondary survey. So this is the correct answer. Now comes the dilemma. Is chest X-ray part of primary survey or not? Simple answer, it is. This is from ATLS. Okay, the ATLS manual. There is something called as adjuncts to primary survey. That means there are certain tests or diagnostic tests. Good evening, Dr. Daivik. So certain tests that are performed to help you in your primary survey, and they are your ECG, pulse oximetry with carbon dioxide monitoring, ABG, catheter, gastric catheter, that is a Riles tube insertion, X-ray of the chest and pelvis. Please note this is very important and it can be asked the next time. X-ray of chest and pelvis is a part of primary survey. Then you can do your fast scan or your extended fast scan, that is a E-fast, and even a diagnostic peritoneal lavage. All these are part of your primary survey. I hope that clears the confusion. So the answer to that question was non-contrast CT. Next question, a patient is brought to the emergency department, stab injury to the chest. Now the patient is unstable, heart rate is 120, hypotension, BP of 90/60, respiratory rate of 28. So the patient is unstable, tachycardia, tachypnea, hypotension. So only two options after stab injury. What are they? Either the patient has hemothorax or the patient has tension pneumothorax. Okay, so simple pneumothorax will not cause all these abnormalities. So it's either hemo or tension pneumothorax. Why not hydrothorax? Hydrothorax is not seen after stab injury. It is more with associated with like pneumonia, a synpneumonic effusion, or let us say a sympathetic effusion because of irritation of the diaphragm. So that is the area where you're going to find hydrothorax or pleural effusion. So in this scenario, we have to come down to hemo or tension pneumothorax. Now you look at the X-ray. Okay, in the X-ray they have shown a white out lung on the right side. So this is a hemothorax, because if air is there, it is going to be a black shadow without any lung markings. So for example, this is where I'm comparing a tension pneumothorax versus a hemothorax. Okay, here you can see completely black lung, shift of mediastinum, you can see lung markings here. Here white out lung, again shift of mediastinum, you can see the trachea is deviated, and this is a hemothorax. So the answer in this particular scenario was hemothorax. Okay, especially with stab injury, most probable site of injury will be the intercostal vessels. Next, let's move on to some surgical questions, that is with regards to surgery. A patient underwent parotid surgery, following which there was weakness near the lower lip. This is a very, very important point. The patient had weakness near the lower lip, this area. So what is the most likely site of lesion? Now, before we look at the answers, this is what Dr. Tejasvi drew yesterday in his class in anatomy. Okay, so it was a very beautiful depiction of the branches of facial nerve. So you are going to have trunk of facial nerve entering the parotid gland. From here, you're going to have two major branches. Temporal goes higher up. Then you have your zygomatic. Then you have the buccal branch. Lower branch will give origin to your marginal mandibular and your cervical branch. Now, the parotid duct runs approximately in this area. Okay, so remember, parotid duct runs approximately in this area. So if there is a damage to any of this area, remember the buccal branch supplies the upper lip. So if there was a damage there, then the patient should have weakness near the upper lip. If it is damage at the main trunk, that means the patient will have all features of the entire area. That means inability to close the eye, loss of nasolabial fold, upper and lower lip weakness, deviation of angle of mouth to the opposite side. Okay, all these will be there. Now here they only mentioned weakness of the lower lip, weakness. So the correct answer in this scenario is a marginal mandibular nerve, because that is what supplies the lower part. But the options did not mention marginal mandibular nerve. Instead, they had mentioned cervical branch and temporal. Now, temporal is ruled out because it's going way high up. Buccal branch is supplying upper lip and not here. And remember, the marginal mandibular nerve, unlike the buccal, will not come like this and come down. It instead comes down and then goes up. So, if you damage here, there is no chance of you damaging the marginal mandibular nerve. So that brings me down to the fact that in case the damage is at this area where the cervical and the marginal mandibular nerve split, that is where you can have damaged the marginal mandibular nerve, and that is why the patient is having weakness of the lower lip and probably even the injury or the damage or to the nerve supply to the platysma. Okay, so my best answer in this option would have been the marginal mandibular nerve, but I know it's not there, so I would have selected the cervical branch. Now this is again straight out of the lecture. I'd even put up a video and I'd mentioned this then also, that if the lower lip weakness is there and the most common nerve injured is the marginal mandibular nerve. Okay, so this was a patient post parotidectomy who had facial nerve palsy. Now let's move on to the biliary system. As usual, AIIMS staff love to ask questions regarding the biliary system. Last time it was gallbladder, this time it was bile duct. Okay, so this question here is, which of the following is not a risk factor for cholangiocarcinoma? Again, here also a lot of dilemma, because certain books say this, certain books say that. One staff said this, one staff said that, my friend said this. So there is a confusion. Let's come down to that. So before we get into the options, again, this is a video out of the lecture which I did where I mentioned all the risk factors. That is primary sclerosing cholangitis, hepatitis C virus, Clonarchus sinensis, and Opisthorchis wavereni, that is your liver flukes, colorectal cyst, and Caroli's disease. They are all inflammatory diseases of the bile duct. Now this is from Bailey and Love, straight out. So from Bailey and Love, they have given options: primary sclerosing cholangitis, hepatitis C, Opisthorchis wavereni, and Caroli's disease or your colorectal cyst. So they've already mentioned all this. So in Bailey and Love, hepatitis B is not mentioned. So if a surgeon has set this paper, the answer in his mind is hepatitis B. Now let's move on to Robbins. So in Robbins' textbook, they have divided your cholangiocarcinoma as intrahepatic cholangiocarcinoma. That means the biliary radicals which are inside the liver, and extrahepatic, and they have called that as biliary adenocarcinoma or your extrahepatic cholangiocarcinoma. So for intrahepatic cholangiocarcinoma, they have mentioned the Opisthorchis, they have mentioned hepatitis B and hepatitis C are risk for intrahepatic. That means for the smaller biliary radicals, in case there is a malignancy, then they would have preferred, what is that, hepatitis B, because Caroli's disease does not involve the intrahepatic biliary radicals, correct? It doesn't go there. So Caroli's disease becomes the answer when you're looking at it from Robin's point of view, or the intrahepatic biliary radicals. But that again depends on what was mentioned in the question. If they have only mentioned cholangiocarcinoma, normally when we use the term cholangiocarcinoma, we are talking about extrahepatic bile duct. Okay, we don't talk about intrahepatic cholangiocarcinoma that often. The terminology that we use, at least in surgical practice, when we say cholangiocarcinoma, is either upper one third, middle one third, lower one third. That is your Klatskin's tumor, middle one third, and your periampullary cancers. That is how we use the terminology. So if you ask me, I would have selected hepatitis B. But like I said, if you're looking at it, or if the question mentioned intrahepatic cholangiocarcinoma, if they mentioned that, then the answer would probably be Caroli's disease. But my best answer would be hepatitis B in this scenario. Now moving on, another question on cholangiocarcinoma, just a follow up. They had asked Clonarchus sinensis is associated with which carcinoma? We have just covered that, and the answer is cholangiocarcinoma. Again, like I had already mentioned, cholangiocarcinoma is associated with Clonarchus sinensis infection and chronic inflammation. This was a very, very, very tricky question, to be very honest. They have asked you that a patient has undergone a thyroid surgery, patient has hoarseness of voice, and which of the following steps will not cause hoarseness of voice? Okay. Now let's look at the options. Okay. First is Bear's triangle and tubercle of Zucker-Candle. Let's finish off those two. Okay. Now Bear's triangle is this triangle: recurrent laryngeal nerve, inferior thyroid artery, and the common carotid artery. Okay. So this is your Bear's triangle. So if you try to dissect here, very high chance you're going to injure the recurrent laryngeal nerve, and you're going to have hoarseness of voice. Tubercle of Zucker-Candle is a protrusion of the thyroid in the posteromedial aspect. That means if this is the thyroid here, posteromedially you're going to have a protrusion of the thyroid. Okay, protrusion of the thyroid like this in the posteromedial aspect. And please note, it sits exactly on the recurrent laryngeal nerve. Many of the times there are surgeons who leave behind the tubercle of Zucker-Candle and say, I'd rather save the nerve than try and be heroic and remove it. Ideally you're supposed to remove, but there are many of the surgeons who do that. So again, if you try to meddle around the tubercle of Zucker-Candle, you will injure the recurrent laryngeal nerve. Okay, tubercle of Zucker-Candle can also cause injury to the recurrent laryngeal nerve and cause hoarseness. That leaves us with the two options, whether it is superior pedicle or strap muscle. First, let's cover superior pedicle. In superior pedicle, what is the nerve we are concerned about? That is the superior laryngeal nerve. There is something called Cernia classification. And again, there is type 1, type 2, in that also A and B. Okay. Here, if external laryngeal nerve is damaged when you're doing that, these patients will only have loss of pitch. Loss of pitch. We also call that as timbre. That means if they are singers and they are used to having high pitch voice, that will not be possible if the external laryngeal nerve is damaged. But hoarseness is not a symptom of external laryngeal nerve. So even if you damage something there, it can't be the recurrent laryngeal nerve, because recurrent laryngeal nerve enters here through the Berry's ligament at the cricothyroid. So here there is nothing. Okay, even if you do something, there is no chance of you injuring the recurrent laryngeal nerve. Certain articles, no textbooks, but certain articles say that recurrent external laryngeal nerve damage can cause hoarseness. Now comes the tricky bit. This is something that I picked up from Bailey and Love. In Bailey and Love, they say incision of the strap muscle is in the midline, but if they say dissection of the strap muscle, okay, dissection. Now this dissection, they have said the plan is to develop and dissect the layer between the muscles and the thyroid, and you're going to do it until the internal jugular vein is identified. Okay, that means you're going to go full posterior and medial and until you see the internal jugular vein. And surprise, surprise, you have to hand it to AIMS or INICET people for asking you such questions, because this is the area where non-recurrent laryngeal nerve is. Now, injury to non-recurrent laryngeal nerve can cause hoarseness. Okay, you can see here this is an image where they have retracted. Okay, that is where your non-recurrent laryngeal nerve will enter. So this is your recurrent laryngeal nerve. Non-recurrent laryngeal nerve will come here. So in case you are dissecting the strap muscle, there is a chance you will injure the non-recurrent laryngeal nerve. So that boils down to the fact what are the terminology used. If they have said strap muscle division, that means the midline, there is no chance you can injure the nerve, then the answer becomes strap muscle division cannot cause hoarseness of voice. But if they have mentioned dissection, just because AIMS people have the habit of thinking out of the box, my best answer at that point of time would be superior thyroid vessel ligation, because I know for a fact there is no way of me injuring the recurrent laryngeal nerve. There is no known anatomical variant where the recurrent laryngeal nerve can come there and get damaged. So now let's move on to another thyroid question. This was pretty straightforward. You can see here the middle-aged woman came with hoarseness of voice and a hard mass. Hard mass. Now, if it is a hard mass, it only has to either be anaplastic cancer or it has to be medullary thyroid cancer. It can't be anything else. And moving forward, they have said the biopsy showed amyloid deposits. Amyloid means only one answer, that is the medullary thyroid cancer. Medullary thyroid cancer. Now we all know that medullary thyroid cancer arises from the parafollicular cells. Follicular cells is going to give rise to the papillary carcinoma and follicular carcinoma of thyroid. Then your Hurdle cells and Ashkenazi cells are seen in Hashimoto's thyroiditis, which eventually becomes Hodgkin's lymphoma. Here the best answer is parafollicular cells, because they mentioned amyloid and they're saying it's a hard mass. Papillary and follicular are more of a fleshy and a well differentiated sort of mass, and they will not cause hoarseness and all. Very, very unlikely for them to cause hoarseness. Now let's move on to one hematemesis question. Now this is a chronic alcoholic. Now the patient had hematemesis. Ultrasound showed dilated portal veins. That means the patient has cirrhosis and has had portal hypertension. Hyperechoic liver, again cirrhosis. Pantoprazole infusion has been started. Here comes the dilemma. What was the exact wording? If they have mentioned what is the next line of management, if a patient has bled, be it trauma, be it hematemesis, what is it? It is hypovolemic shock or hemorrhagic shock. What are you going to do? You're going to resuscitate. First thing is resuscitate. So if they have mentioned next, then the best answer will be IV fluid and electrolyte replacement. This will be your first step. But if they have asked what is the best line of management, that becomes upper GI endoscopy with variceal band ligation. Variceal band ligation. You can also call this as EVL, endoscopic variceal ligation. So this is again from our lecture notes. I told you first step is IV fluids, but if you're asking best, that means endoscopy. In endoscopy also ligation, that means your endoscopic variceal ligation is the best, and if that is not possible, then you're going to do endoscopic sclerotherapy with sodium tetradecyl sulfate. So this is an image of patient with esophageal varices. This is at the lower end of esophagus, and this is an image of a patient with fundal varices in the upper end. This is fundal or gastric varices. Gastric varices. Now another question. This was very, very easy again with regards to shock. Now patient presented to the ER with symptoms suggestive of anaphylactic shock. Forget about everything else. This was pretty straightforward. Shock means what? Hypoperfusion. Hypoperfusion means what? The patient will have hypotension. Hypotension. And if you go forward and look at the question says which of the symptoms will not be seen in this patient. So if the patient is having hypotension, he cannot have hypertension. Okay, the patient cannot have hypertension. So hypertension was the correct answer there. Now last question they've asked, patient requiring immediate care in the casualty, urgent care in the casualty, or immediate care. What category of triage does this fall in? This falls under red category. Okay, red category. Let us just quickly revise the table. Now you're going to categorize them as red, yellow, green, and black based on what the need is. If it is immediate care, it is going to be red. That means they are critical and they will survive if you urgently jump in and do something. Yellow is urgent, that means they need help, but first look after red, then come back to these yellow categorized patients. Green is non-urgent. These are called as a walking wounded patient, WW. Remember, walking wounded patients come under green. Black is moribund or unsalvageable patients. That means no matter what you do, there is a chance you're going to lose the patient. So don't waste your effort and time and lose out on other critical patients. You need to know when to hold yourself back. Okay, so that is black. So again, in this question, they had asked immediate. Okay, they had asked immediate. So the answer is red category. So these are all the questions that were asked straight out of general surgery. I hope you have got most of them right, and there are still one or two dicey questions that I've given you my substantiation as to why I think it's the best answer, and I've given you the references again from standard textbooks, not from internet articles, because that is what you guys need to know at the end of the day. And I also hope that our explanation of the question that I've given now will help you for your upcoming NEET exam, and all the very best for it. And if you have any doubts or questions, please put them up in the chat box. I will hang around for a minute or so, and if there are any questions, I will take them. Or else, all the best. Enjoy the match. Enjoy today's IPL match, and tomorrow is a fresh day. Start planning. Get your NEET schedule in order and get it. Now, for those of you who are watching this video at a later date, first and foremost, please subscribe to Manipal MedAce. There is a free trial period. Go through our crash course at least. This is typically curated for your FMG, INICET, and your NEET exam. Okay. Now with the NEET coming up, I'm sure all of you want to do really well. So if you have time, at least go through our crash course. Wonderful. Subscribe to our YouTube channel. Ask your friends also to subscribe. They're putting up lots of nuggets. Okay, of videos of 1.5 minutes. Please go and watch them. They're lovely. Okay, we have covered entire topics in 1.5 minutes, like how you watch reels on Instagram, which comes up with a lot of information. And if you have any doubts, please, you can always send me a mail on lkanta.57@gmail.com. So I have two WhatsApp groups, Surgery Made Easy and Simplified Surgery, where we discuss a lot of interesting cases and questions. So drop me a mail and I'll send you the link and few PPTs which will help you in your exam. And that's about it. So if there's nothing else, I'll sign off. Thank you, Dr. Dhanlakshmi. Thank you so much. Thank you for being there with me. All right then. Signing off then. All the very best, and I'll see you all pretty soon, hopefully as bright young junior residents or residents in your respective postgraduate departments. Thank you so much.